Oh, okay. Hello, everyone. Hello there, everyone. Today we're going to be talking about cardiac arrhythmias. It's chapter 13 in the Guide to the Whole Physiology book. My name is Muneeb Ismat, and this is the cardiac arrhythmias 2. This is the interactive session. Okay, so let's go on. What is pulse deficit? All right, so pulse deficit is basically when you have a deficit in your pulse, right? So it can be like you have a very fast heartbeat. But basically what it is that when you touch your radial artery and you don't feel a pulse. And it can happen from premature contractions such as extrasystole, premature beat, or an ectopic beat. What is an ectopic beat? An ectopic beat is basically when you have a muscle, a cardiac muscle that works stronger or like overcomes the work of the SA node and the AV node. And we're going to see a few examples of it today. And a pulse deficit can be caused by local area of ischemia, small calcified plaques, toxic irritation of the AV node Purkinje system, or myocardium, nicotine, drugs, and caffeine. So excessive intake of caffeine can cause pulse deficit. As a shout out to whoever takes Red Bull or drinks like too much coffee, you could get pulse deficit. Anyways, moving on. Premature atrial contraction. So what is premature atrial contraction? This is when you have an ectopic pacemaker that takes place in the atrium near the AV node. If you guys take a look at this picture here, if you guys look at the star, this star is basically the ectopic pacemaker. And what it does is that it basically all right, let me make this simple for you guys. It generates an action potential that overcomes that of the SA node, right? It basically pushes the P wave a bit further. It gives P wave more energy, you know what I mean? If you guys take a look at the ECG picture on the top right, the normal heart rhythm is normal. The P wave is normal. However, in the premature atrial contraction, you guys can take a look and you can see that the P wave it goes higher. Not only that, but it's earlier. It's an early P wave. So you basically have an early P wave as well as it has an abnormal shape. That, along with that, you can also see that the PR interval between the first, you can also see that the PR interval here, the first depolarization, the QRS and the other QRS, you can see that it is shortened. So you have a shortened PR interval, and you also have irregular RR measurements. All right. What you have after the premature atrial contraction is what we call a compensatory pause. The heart takes a pause, takes a breath, you could say, and then it gets back to normal. Then it gets back to beating normally. The closer it is to the AV node, the shorter the PR interval. So the closer this ectopic pacemaker is closer to the AV node, the shorter the PR interval is going to be. Why is that? Because it's going to be sending impulses into the AV node, and the AV node normally what it does is that it delays the contraction. However, if you keep on giving it contractions, you're not going to cause a delay. You're going to make the PR interval faster. All right, perfect. Moving on. AV bundle premature contraction. What is AV bundle premature contraction? This is basically when you have the ectopic pacemaker closer to the AV node, and it also sends two impulses. It sends an impulse backwards to the atria, to the SA node, and an impulse that goes to the ventricles, right? So this you might make you feel that the P wave is missing. However, it's not missing, it's masked by the QRS complex, right? So when it sends an impulse, if it sends it to the ventricles first, the P wave is gonna have to come after the QRS, right? So the QRS is gonna happen before. So if you guys take a look here at the ECG, you guys can see that the QRS and the premature beat, the QRS happens before the P wave. So you guys have P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave. However, there's no P wave. You have a straight on QRS, and then you have a P wave after it. So that's what happens when you have what? When you have the impulse going to the ventricles first before the atria. However, when you have them at the same time, the P wave can be masked by the QRS complex and it cannot be seen. So basically in these types of contractions, you need to take a really close look to the ECG, double check where the P wave is, because if you don't see the P wave, like this one is a bit like hard to detect, but yeah, that it's either you don't see the P wave, it's masked by the QRS, or it comes after the QRS, and that is called AV bundle premature contraction. Premature ventricular contraction. So what is premature ventricular contraction? Same thing, you have an ectopic pacemaker, however, where is it this time? It can be anywhere in the ventricles. And when this happens, you have a wider QRS. If you guys take a look at the ECG, the QRS is prolonged. Not only that, but the QRS has a higher voltage. Why is this happening? All right, so normally in the heart, you'd have the atria contracting and then the ventricles contracting together. And when the ventricles contract together, they would neutralize each other. All right, so here we don't have that. The ventricles depolarize separately. So you're not going to have the neutralization, and that's going to cause a higher QRS voltage. The voltage is going to be higher because they don't neutralize each other out. Not only that, but you're going to have a wider QRS impulse because the muscle fibers are slower in conduction than the Purkinje system, right? I'm not saying they're weaker, they are stronger. However, they have slower conduction, all right? They have slower conduction. And remember, Purkinje system has the fastest conduction because it has the gap junctions. All right, now moving on. Now you guys may ask me, why is the T wave inverted? Why is the T wave going down here? All right, now, if you guys remember, I said that one of the ventricles contracts before the other. Now, if you guys take a look at my cute vectors here, my nice vectors, you can see that the second arrow, it's the contraction is happening before the arrow number 3, the vector number 3. So you guys can tell, we took this before, the first to depolarize is going to be the first to repolarize. And if they're not depolarizing together, then we're going to have one side that repolarizes first, the other side that depolarizes after. You know what I mean? You know what I'm getting at? So basically what we have, we're going to have depolarization, then repolarization in one ventricle, while the other ventricle is still getting depolarized. And that is what causes an inverted T wave, all right? It's going to make it negative. So the vector number 2, this is during depolarization, this is before repolarization. When it starts repolarizing, it's going to go to the negative, and the other one is going to be going to the positive. The positive is going to give you a negative wave, and that's why the T wave is inverted. Now, what are the triggers for this premature ventricular contraction? You have caffeine, drugs, smoking, stress, lack of sleep, and mild toxicities. Many premature ventricular contractions happen from re-entry near infarcted tissue, and this causes a high risk of ventricular fibrillation, and we're going to talk about all this in a second. Dangerous when premature ventricular contraction hits the vulnerable period at the end of the T wave. So when it hits at the end of the T wave, that is the most vulnerable period, and that can cause ventricular fibrillation, and we're going to talk about this as well in a second. Now, long QT syndrome. Now, this is a genetic mutation that normally happens in sodium and potassium channels. And what it does is that when you have a gene mutation with sodium and potassium channels, they're not going to be able to close, all right? So you're going to have prolonged QT interval, you're going to have delayed repolarization, and you're going to have prolonged action potential of the ventricles. The ventricles are going to stay depolarized, you know what I'm saying? They're not going to repolarize. They're going to repolarize, but after a delay. You see what I'm getting at? So when they're in that period, like before repolarizing, this increases susceptibility to ventricular arrhythmias, and that is called Torsades de Pointes. Right? So prolonged action potential, this causes premature depolarization before full repolarization. Before it repolarizes, you're going to have repeated premature beats, repeated premature beats. So we're going to have repeated premature impulses getting in. You're going to have repeated premature impulses into the muscle, and you're going to have risk of triggered activity of chain depolarizations. So now, if you guys take a look at the ECG, you have a prolonged QT, and then you have constant depolarizations. This is called a chain of depolarization, and that is tardive points. All right. You guys may ask, why does this happen? This is caused by plasma electrolyte disturbances, especially when you have low calcium, low potassium, and low magnesium in the blood. What it causes, it can cause fainting, it can cause you to go to sleep, I guess. Ventricular arrhythmias can deteriorate into ventricular fibrillation following physical exercise or intense emotions. All right. All right. So now, paroxysmal tachycardia. What is paroxysmal tachycardia? What does paroxysmal even mean? Paroxysmal simply means it suddenly appears and then it suddenly stops. It's not continuous. This happens when a rapid re-entry circuit forms, causing a localized area to fire impulses very quickly. That area, it overrides the sinus node and it temporarily becomes the pacemaker. Now, these episodes can last from a few seconds to hours, and then the sinus node takes back control. Sometimes we can stop it by increasing vagal tone, like pressing on the carotid sinus, which slows down AV node conduction and can break the re-entry circuit. We're going to talk about what re-entry circuits are in a bit. There's also antiarrhythmic drugs which work by blocking the sodium channels. Now, normally during depolarization, sodium permeability rapidly increases. These drugs blunt that. They slow down conduction in the irritable focus, and by reducing excitability, they help stop the rapid firing that sustains paroxysmal tachycardia. Right. Now, moving on, we have atrial paroxysmal tachycardia. What happens in atrial paroxysmal tachycardia is that the rate is typically between 95 and 150 beats per minute. So it's fast, but however, it's still organized. The key ECG clue is the inverted P wave. Since the pacemaker is not the SA node, the atrial depolarization spreads in the opposite direction, right? And that gives an inverted P wave. So normally the SA node would go from up to top. Like if you guys remember the vectors, it goes from negative to positive. So the P wave is positive. However, here, the pacemaker is not the SA node, and it goes in the opposite direction. It would go from positive to negative. And that's why it gives it an inverted P wave. Now, if the ectopic focus is close to the SA node, the P wave can look nearly normal, so we have to look carefully. Sometimes the T wave actually hides the inverted P wave, so it can be subtle and easy to miss. You need close inspection of the ECG. Now, if you guys take a look here at the ECG, you guys can see PQRST, PQRST, there's no P. Where did the P go? The P is inverted, right? Now you have an inverted P, QRST, inverted P, QRST, and so on. Alright, moving on. AV nodal paroxysmal tachycardia. Now, this is the most common form of tachycardia in adults. Almost normal QRST complex, but a total missing or obscured P wave, right? Ventricular paroxysmal tachycardia. And what happens here is that you have a rhythm disturbance where the ventricles fire rapidly due to abnormal electrical signals, producing a series of premature beats without any normal, healthy beats interrupting them. Now, this usually happens when there's a significant ischemic damage, meaning areas of the heart muscle have been deprived of oxygen for too long, like after a heart attack. The real danger is that ventricular tachycardia can easily deteriorate into ventricular fibrillation, a chaotic, uncoordinated rhythm where the heart can't pump blood effectively, and we're going to talk about this in a second. Now, Ventricular fibrillation. So, what happens in ventricular fibrillation? So, in ventricular fibrillation, it's basically one of the most dangerous cardiac arrhythmias. Instead of a coordinated pumping action, the ventricles quiver due to chaotic electrical signals. Now, small areas of the ventricles start exciting others in a loop, with no central coordination, meaning the muscle fibers contract randomly. This leaves the heart neither fully contracted nor relaxed, so it can't pump blood effectively. Cardiac output drops to almost zero. Without blood flow to the brain, a person will lose consciousness in just 4 to 5 seconds. If defibrillation isn't performed within 1 to 3 minutes, the condition becomes fatal. Ventricular fibrillation can be triggered by a sudden electrical shock, like from an accident or from severe ischemia, often after a major heart attack or due to damage in the conduction system. Right? So basically what you have is some ventricular muscles that contract while others relax, no coordination, and no blood is going to be pumped effectively. And that causes unconsciousness. Alright. Now we've finally came to re-entry. What is re-entry? Re-entry, now if you guys take a look at the picture in the top right, the normal pathway, this is a normal cardiomyocyte. What happens, it gets depolarized, right, and then it gets absolutely refractory. So it becomes depolarized, it activates, and then it becomes absolutely refractory. It rests, it contracts and it rests. However, in the long pathway, you're going to have re-entry. Now, what is re-entry? Re-entry is basically re-entry. Now, you ask me, what is re-entry? Okay. When you have a long pathway and the impulse, alright, so the impulse happens in the long pathway in the cardiomyocyte, it gets depolarized. What happens is that you have a part that is already repolarized, a part is that is relatively refractory, and a part that is absolutely refractory. So it's kind of like a cat trying to bite its tail. So what happens is that the impulse, once it hits the cardiomyocyte, and that cardiomyocyte, it becomes depolarized and then repolarized. Because it's a long pathway, there's going to be a small entry for that impulse to depolarize that cell, that cardiac muscle again. And that's why it's called re-entry. That impulse, it keeps on re-entering, it keeps on re-entering that pathway. And it keeps on causing depolarization and repolarization of that muscle. So when does this re-entry happens? When we have a long pathway, when we have slow velocity of conduction. Remember, if you guys remember when we talked earlier that the ectopic pacemaker, it is slower than the Purkinje fibers. This causes re-entry. We also have short refractory period, right? And this is the short refractory period basically happens when you have a long pathway. All right? When you have a long pathway, you're going to have a shorter refractory period. Kind of like a cat trying to bite its tail. Like a cat keeps on running around itself in a circle and it keeps on trying to bite its tail. That is basically what is re-entry. And the causes of this is like a dilated heart, ischemia, Purkinje block, high potassium, drugs such as epinephrine, electrical stimulation. Now, what do all of these things do? So in humans, if the heart is dilated, which increases the path length, this increases path length, conduction can slow down due to things like ischemia. So let's break it down. Dilation of the heart causes increasing of the path length, a longer pathway. Conduction can slow down due to things like ischemia. So ischemia and damage to Purkinje fibers, that causes slower conduction. Or high potassium levels. The refractory period may shorten with certain drugs like epinephrine or after repeated stimulation, allowing the tissue to be re-excited too soon. Now, all these conditions set the stage for a self-sustaining loop of electrical activity, causing chaotic muscle contraction and ultimately ventricular fibrillation. Now, what exactly happens in ventricular fibrillation? So, what happens in ventricular fibrillation? Basically, we have a stimulus point, don't we? Now, let's look at this diagram. We have a stimulus point. All the impulses are, going to the ventricles. However, several disruptions can cause ventricular fibrillation. Now, if conduction is blocked in one direction but not another, or if the heart is stimulated too rapidly, things start going wrong. Rapid stimulation slows conduction and shortens the refractory period, allowing impulses to re-enter areas that should be resting. When a depolarization wave reaches a partially refractory zone, it may split and it could travel around it. Now, take a look here. Once you get a stimulus point and you get impulses going released from it, you're gonna have refractory patches in the heart. Those refractory patches, when impulses go to them, they're gonna get blocked. And this all happens in rapid stimulation. So you're gonna have impulses that are blocked because they hit the refractory patches. You're gonna have impulses that branch out when they come near refractory patches, and they're gonna go around and they're gonna depolarize the muscles that are excitatory. And that is gonna cause rapid stimulation. That is caused by rapid stimulation, but that is gonna cause re-entry. So when that happens, you're gonna have re-entry circuits forming, chaotic and uncoordinated contraction. And if you guys take a look at heart B, this is the final form of ventricular fibrillation. How do we stop ventricular fibrillation? Defibrillation. You give the guy an electrical shock. You put all the muscles in refractory period, or manual chest compressions like CPR. That's like at the start. Why do we do that? It makes all muscles refractory, stop all abnormal circuits, let normal rhythm restart. Basically, you give it like a restart, just like a computer, When the computer starts lagging or something, give it a restart, it all starts working again. Same thing with the heart. Alright, now, atrial fibrillation is the same re-entry mechanism as ventricular fibrillation. It affects atria only, not the ventricles. It is caused by atrial dilation. We've spoken about dilation before. Ventricular failure causes atrial congestion, right? Now, what is that exactly? This is basically when you have, due to chronic high pressure or ventricular failure, it leads to blood packing up in the atria, right? So, as a result, the atria stop working as effective primer pumps. Fortunately, the good thing about this is that most ventricular filling still occurs passively, so the blood still moves passively to the ventricles. So people can live without, or they can live with atrial fibrillation for years. However, when you have stagnant blood in the atria and the atriums, this can cause blood clots, right? So you're not pumping the blood effectively from the atrium, so this is going to cause stagnant blood, and these are going to cause blood clots, which can then dislodge and cause strokes if they go to the brain. And that is why those patients are given anticoagulants. Alright? So on the ECG, what do we see? If you guys take a look at the atrial fibrillation, you see no P waves, or you see high frequency, low voltage P waves. They look a bit weird. And they are treated with electroshock just like ventricular fibrillation. Alright, we're almost there. We've got a few slides left. Atrial flutter. Electrical signal travels in a large wave around the atria. Atrial contraction rate is 200 to 350 beats per minute. It's really, really fast. Alhamdulillah, sorry. Partial contraction, some areas contract while others relax. Minimal effective pumping. Heart is not going to be pumping effectively. Because the contraction isn't uniform, some parts of the atria contract while others relax. So you're going to have some part contraction, some part relaxing. The efficiency drops. The AV node acts as a filter, allowing only some of these rapid atrial beats through to the ventricles, and this results in ventricular contraction rates that are usually slower, often with 2 or 3 atrial beats for every ventricular beat, and this is known as the 2-to-1 or 2-to-3 conduction ratio. So you're going to have 2 atrium beats to 1 ventricular beat, or 2 atrium beats to 3 ventricular beats. Wolff-Parkinson-White syndrome, this is an example of congenital malformation. People are born with this, and what they have is that they have an accessory pathway which they shouldn't have. The accessory pathway basically allows impulses to go from the ventricles to the atria, and this basically causes it can set up re-entry circuit that leads to episodes of rapid supraventricular tachycardia, which can be dangerous. What do we do to these patients? They are given drugs like a drug called procainamide, but importantly, AV nodal blocking drugs should be avoided. Like, if you block the AV node, khalas, this guy dies, right? You should never block the AV node. Sometimes they are given catheter ablation, which is referred basically like you iron the accessory pathway. However, if the accessory pathway is close to the AV node, you don't iron it, so you know. But anyways, this isn't really important. This isn't related to our topic. It's just an example of congenital malformations. You just need to know that the impulses, they go from the ventricle to the atriums, and this also causes ventricular fibrillation. Now, what final slide, what is the difference between heart attack and cardiac arrest? Heart attack is when you have blockage or narrowing of the coronary artery. Cardiac arrest is electrical, is when you have a problem with the electrical system, AV nodes, SA nodes, whatever. So the symptoms, the heart attack may occur hours or days before symptoms are recognized. Chest pain, fatigue, weakness, nausea, difficulty breathing. However, in cardiac arrest, the guy just collapses, becomes unconscious, no breathing, no pulse, and hopefully none of us get heart attacks or cardiac arrests. And thank you guys for watching this lecture. That's about it.